Well, I think I referred to this in the answer to my previous question. I think for OBRA 89, the main difference was that categorical programs were, for the first time, were block granted into a formula grant to states. The result of that created a difference in the way we do business. Federal government had less direct involvement, less control. Our role was pretty much one of technical assistance to increase the capacity of states, not to dictate and regulate what states did. With that, states had far more control and far more flexibility in how they use funds, and they do to this day have far more flexibility and control over funds than, say, other programs within government, such as education, that is very regulation-driven. Title V is not regulation-driven, and I think that has been a good thing over the past 3 decades that's allowed us the flexibility to reinterpret, to redefine, to expand as we need to within the structure of a block grant. Politically, certainly, in this day and age, the block grant has been a big asset to MCH in that it's the way that government likes to do business at this point in time. And I think that we're seeing the benefit of the block grant in this administration and in the last administration. I think it's also important with OBRA 81, although it's not directly children with special health care needs, is to recognize that this was the point where the waivers really got expanded. The 1115 waivers already existed, but with OBRA 81, we also got the freedom of choice waivers that allowed states to pursue mandatory managed care for certain populations of children. I've seen that as children with special health care needs are being moved into managed care environments. And then that home and community-based services waiver, now known as the Katie Beckett waivers, allows states to cover home and community-based long-term care services for elderly and individuals with disabilities, and at home or in other environments rather than in institutions. And as I said, these later became what is known as the Katie Beckett waivers. So in between OBRA 81 and OBRA 89, there was something called OBRA 85, and we didn't pay much attention to it, but this is really the OBRA that changed the terminology for children with special health care needs from crippled children to children with special health care needs. Boy, that was a big change because as time had caught up with us, crippled children and handicapped children really was not only not politically correct, it simply wasn't a very sensitive term to use. And so I think changing this terminology was an early indicator that the country was thinking very differently about this population of children and no longer wanted to keep it so narrowly defined as crippled children or children with orthopedic handicaps. So that was a big change, although OBRA 85 didn't spur the change. It actually deserves recognition because it actually was the point in time when we actually changed the terminology that we used. But then 4 years later came OBRA 89 with the big sweeping changes. And for children with special health care needs, the big change here was expanding the scope and the authority of the Title V programs. There were many, many other sweeping changes in OBRA 89, but in the interest of time, I want to just focus on the one that has driven what we did for the next almost 30 years. We could still provide direct services to children with special health care needs, as we historically had done in children with special health care needs programs and in the preceding children with special health crippled children's programs. But now that authority and that responsibility was expanded. Not only we would be providing direct services to children who were recipients of SSI benefits if they weren't already covered by Medicaid, but we also had this new responsibility of providing and promoting family-centered, community-based coordinated care, including care coordination. nobody really knew exactly what that meant at the time, but it has come to represent one of the hallmarks and one of the defining characteristics of maternal and child health in general, not just children with special health care needs. And then the next piece of that, again, groundbreaking, was our expanded responsibility to facilitate the development of community-based systems of services for children and their families. We were no longer just a program that paid for direct medical care for certain children. We may still do that, and we still have the authority to do that, but now we had the responsibility and the authority to look at the entire system of services and how all of those services fit together to best meet the needs, not just the healthcare needs, but all of the health needs, medical needs, and well-being of this population of children and their families. So it was groundbreaking. Not specific to children with special health care needs, I think it's also important to recognize that this was the legislation that expanded EPSDT to include the diagnostic and treatment components not covered under state Medicaid programs. And that's been a big, I think, challenge, even today. But that's where the authority came from. And also, I think OBRA 89 is, in the context of children with special health care needs, it's important to emphasize that OBRA 89 is really where we put some teeth to our mission. We had much stricter requirements about the use of funds. There was an accountability dimension added in the way of needs assessment, annual reports, applications. So we actually did have far more restrictions on how that money got spent as a result of OBRA 89.